Hey, good afternoon, everyone. Welcome back to another edition of what you need to know about COVID-19. And joining us, as always, is Dr. Philip Keiser. He is the local health authority for Galveston County, as well as the interim CEO of the Galveston County Health District. And Dr. Keiser, it feels like, hey, wait, I just saw you, but it's right, I did just last week, right?
Last week.
After we skipped out, but we wanted to get on some bigger news last week, so we'll probably revisit a few things we discussed on Friday.
Sure.
But some new stuff since, and this is how these things always change.
Yeah.
And the big news that obviously we found out over the weekend, the death of Colin Powell, the former Secretary of State, former commanding general of the armed forces during the first war in Iraq. I just wonder, one of the things it is that the statements are that he died of COVID-19.
Mm-hmm.
But he had an underlying cancer condition that affected this as well. So I wanted to start with that, kind of explain to folks, because he was vaccinated. It was a breakthrough case,
Right.
But to give people some context, because then I want to drill down into something else that always comes up as a topic when we talk about folks who are infected, vaccinated, or who may die of something related to COVID-19. I just wondered if you could give us a take on what you know about this case as well.
Yeah, well, what I know is just, what's been reported in the news. I mean, it was shocking to me. I, like many, I'm sure, remember Colin Powell was this very vital, strong soldier. And, to hear that he died was both sad and shocking. But he had a disease called multiple myeloma. And multiple myeloma is a form of blood cancer. But one of its major effects is that it inhibits the ability to make antibodies. And so people with multiple myeloma typically die from infection, or they die from bleeding. And it's not uncommon for us as infectious disease experts to see people with multiple myeloma when they're reaching the end of their lives. And so what has happened to Colin Powell was that he had multiple myeloma. He got vaccinated, and even though he was vaccinated, he was not able to mount a good antibody response to keep him from getting COVID. And then finally, it took its course, and it took his life.
One of the things that we had talked about, and is he revealed in an interview with Bob Woodward of the Washington Post, that also, he was 84, which I think you and I both commented on. That was kind of jarring for both, because we don't think about him as being in that age. Also, too, he had Parkinson's, as well as this blood cancer, and as we said, was vaccinated and due for a booster at some point.
Yeah.
But it goes into the bigger question I wanted to ask you, and that's because as we are talking to folks about being vaccinated, getting out there, doing the best things to protect you, we get a lot of questions from our viewers all the time of, well, what if I have this? Or what if my uncle or aunt have this? And cancer is one of the big questions we get all the time. And the other is pregnancy. So those are the two. Now that's not disease, obviously, but I just wonder, what are things that folks should be looking at about vaccination and protecting themselves? Second, what's down the pipeline, or what's being discussed about ways to treat folks maybe different from the vaccine to be able to battle off COVID-19?
Yeah, so there are a variety of things that I think people would need to realize. So, if you're in a high risk group, you should have gotten a third shot, or now, even if you got J&J, a second shot. And people think of boosters. Well, I don't. I got Moderna. I can't get a booster. But there's this category that the CDC and the FDA first came out with, of people that are immune suppressed. And that's in quotes, but it's also, I think, a very, very broad category. So, I hadn't thought of someone with multiple myeloma, but certainly that's one of those categories. And there are many types of cancers that would put people in a very high risk group. And you should have gotten a third shot if you haven't gotten one yet. And so I think that's a very important thing to realize, is that the people that are immunosuppressed have underlying diseases that make them at high risk for having a very bad outcome with COVID. And there's no question you should get a third shot. As far as boosters go, now we're into the point where we have boosters for Pfizer. In the next few days, we'll have boosters for Moderna and J&J, and we may, even in a short period of time, even have boosters where we're mixing and matching boosters, where, okay, you got Pfizer, you should get Moderna. You got J&J, you should get Pfizer or Moderna. Don't be surprised if you hear that within the next few weeks or so, because the FDA is going to be considering that, and they've actually asked their advisory panel to give them advice on how to mix and match the vaccine. So that's something that's coming down the pike. Now, one of the other things, and it's particularly germane with the story of Colin Powell, is that since his body was not able to mount antibodies, he may, and I say may, have benefited from getting these antibody infusions like Regeneron, like President Trump got. And these are, in his case, it may have actually been something where he could have gotten it once every 90 days or so. I don't know whether he did. I don't know whether people thought about it. It's not approved by the FDA at this point. There's been talk about that. We may see that coming down the pike, and we may see it coming down the pike even sooner now that this has happened. Certainly, we are giving Regeneron as prophylaxis to prevent people who are at high risk, who have potential exposures to COVID, to keep from getting it. So, so there's, in terms of the regulations and the guidelines, there's wiggle room for a case like this. The bottom line, if you're not sure what to do, you should be talking to your doctor about that. And if you have any one of these diseases that's on this list, and it's a really long list, you should be talking to your doctor about what the best thing is. I don't know the particulars of your disease. I don't know the particulars of someone else's. And even with the disease that Colin Powell had, there are people that have, mild disease. There are people that have early disease. And obviously his head was a late stage disease that he was in a position where the vaccine wouldn't work and all the other therapies wouldn't work.
Let me ask though, because it goes into, as I say, a broader question, and we've had this general discussion in the past, and it's about antibody infusions like Regeneron that we talked about, versus vaccine. That it's kind of like the flu approach to things. There are people who won't get the flu shot.
Right.
But the moment they get sick, they will go and ask the doctor for Tamiflu. There's nothing wrong with that as we look at the flu. We think, but still the recommendation is the best thing. Get your flu shot, and then if you get sick, then do this. But I wonder, because there's going to be, Galveston County, 70% of the eligible residents have now received the vaccine. In some form, either one shot.
At least one shot. That's right.
At least one shot.
Yeah.
But I'm curious on this, and because this gets us into kind of that next phase that we've long talked about would get there, but maybe now is the time to have the conversation. Particularly too, now Merck's coming out with the pill that we're going to talk about here shortly. But should there be the therapies and treatments? Should that be the new emphasis now? Not necessarily the vaccines. Yes, we got to still focus on those, but now treatments and therapies be the focus, such as antibody infusions versus a vaccine. Maybe not versus is the right term here, but that folks say, listen, because I'm in pretty good shape and I don't really want to get the vaccine, but if I get sick, I'm all for getting an infusion.
Yeah. And
I know that's the recommendation is against that, but are we getting to the point just like we did with flu and other, actually, I don't want to use flu to downgrade this, but other treatments where it's like, okay, we're not going to give you the vaccine, you've not wanted that, but we're going to do, here are the effective treatments. Have we gotten to that point now?
No, I don't think we're there yet. So, but I understand why people think that way. I look at this from a very different point of view. It's sort of like, we're going to war and you're asking me, would I rather have a bayonet or a grenade or a rifle, and my answer is I want them all, and so these are all tools that we can use. None of them are perfect. And this is the problem, vaccines are not perfect. The flu vaccine, efficacy about 50%. I mean, COVID vaccines are so much better than that. And but both COVID and flu vaccines are really good at keeping people from dying from flu or from COVID. So that's why we want people to get it. And then things like Regeneron works very well when given early on to people who are kind of on the margin. If you get past a certain point, it doesn't work, and that's one of the dangers of looking at, say, well, I don't want the vaccine. I'm going to wait till I get sick and I'll get the antibody. Or I don't want to get the infusion. I'm going to wait until the pill comes out and I'll just take a pill, And so at the end of the day, in 6 months, it wouldn't surprise me if we've got all of the 6-9 months a year, we have all of these things available and we'll be using them all. And we will know how to use them very well together. But every one of these things is a very imperfect way of stopping this virus. And there are people with the pills, there are people with the antibody infusions, there are people with the vaccine that get sick and die. So if you really want to protect yourself, you need to have all of these things available to you.
And while Secretary of State Powell, General Powell, I always find myself referring to him as General in this, even in all of this. Even though
he probably like that. He probably
yeah. But he was the first black Secretary of State. So I want to make sure we give him due to that, of that position. But because he's high profile, it became well, look, he was vaccinated, and he still died. But again, the contributing factors that come in there. That goes into the next question I was going to ask you about, is that every single day we get a list from the health district of the latest numbers in COVID. And when there are folks who have died, the list includes their age bracket, male or female, and it will say not vaccinated, vaccinated, and then it will say underlying conditions.
That's right.
Now, given, and I'll bring up, for example, the Kaylee Cook situation, which is still, by the way, as we talk, is not resolved for sure, even though the thought process is it's going to be COVID. Right. But I bring that up because that did kind of expose this type of what is really supposed to be done to say, yes, this is a COVID death. Now, this one, the Kaylee Cook, I want to make this a separate. There was no physician's care going on at this time. It wasn't someone under some type of treatment plan at the time. So that's a different situation than most of these are. When we see those deaths, it's someone under a doctor's care at the time, or being treated in the hospital. There's those underlying conditions are being monitored that are there when it says so. I'm going a long way, kind of stressing it to say, on the regular basis, though, how much are the underlying conditions, overall percentages, more responsible for the death versus COVID, or is it COVID gets put in there not just because they tested positive, but because this sped up the death based on what we know about what they had?
Yeah, as best as we can tell, it's the latter. And so, here's our process. We obviously know a whole lot more about these individuals other than their gender and their age, and whether someone said they had complications or not. We have access to, their medical records and review their cases and just make sure that everything fits together. So, as part of the review process, if you're riding down the street with out your motorcycle helmet on the back of the bike, and you're pretty well lit and drunk, and you fall off the bike and die, and you test positive for COVID, we're not counting you as a COVID death.
Right.
We're counting you as a Darwin Award death. Somebody who did something dumb and got killed. But in the cases that we see, if you look at, there are commonalities among the people that die, and most of them are over 65. Most of them have serious underlying illnesses, and by complications, we're not saying, oh, you have a little diabetes and your diabetes is well controlled. I mean, that'll count in there, but that's not really what we're seeing. We're seeing primarily people with illnesses that are out of control, diabetes out of control, blood pressure and heart disease that's not treated, or just really very elderly people who are very frail. And it doesn't matter in many cases what kind of illness that they get that kind of tips them over. They just don't have the reserve anymore. And they die, but they do die from COVID. It is the COVID that kills them. Their bodies aren't strong enough to fight it off anymore. So that's what we're looking at. And then we add in the additional factor of, are they vaccinated or not? And so what we have seen over and over and over again is that it's people that are older, people that have multiple risk factors, and then primarily people that are vaccinated. We've vaccinated over 200,000 people in this county, and we have about 24 deaths of vaccinated individuals. So I think that really speaks to itself about how well the vaccine works.
And that's 24 days, when folks will go, what? That can't be right. Quite frankly, even though it's 500 plus deaths in Galveston County from COVID-19, the vaccines weren't readily available. Well, let's just say available until December of 2020.
That's right.
And then not readily available really until probably February, March.
Yeah,
around there, where it was going beyond, it was stretching out to seniors. And I bring that up because that has been from day one of the things you and I always get questioned about is, well, those are underlying conditions. Those were underlying conditions. And it's yes, but this is part of the factual information. Yes, they were. But as I have tried to explain it to folks, when you see that, that means that they've looked at it and that COVID sped this along.
Right.
That they would not have necessarily died at this time or within a short period of time because of the disease they already had or underlying conditions, that this was sped up at some point.
Yeah.
I liken it to someone can have the cold if it goes untreated for a while, become something more severe, and then the next thing you know, you have pneumonia. You die of pneumonia at that point. It's an untreated at that point.
Right. That's actually a very good analogy, but it also, I think, if you think it through, it helps explain what's going on. So most people, when they get a cold, don't get pneumonia, right? And so usually there's something else going on that would actually go in to get pneumonia. And then even most people that get pneumonia don't die, right? And so, so the shape our bodies are in, our age, our general overall health has a lot to do with how well we respond to infection. So if you would argue to me that it's unusual, and it is unusual, that a 30-year-old would die from COVID who's perfectly healthy, and when I say perfectly healthy, I mean perfectly healthy. Yes, that is unusual, but it actually has happened, because there are other things about COVID that we still don't understand. But in general, when we see even younger people dying, just as older people, they have some sort of underlying condition which makes them more susceptible to either getting really sick from COVID or dying from COVID.
But again, when the folks see that, there's a thought process. So just to reiterate, there's a thought process that's gone through that is saying this underlying condition, yes, it was there, but it's not just, it wasn't, it was just there. This was part of it, but it's exacerbated the death.
That's exactly right. And so another way of thinking about it is that on death certificates, anytime a death certificate is filled out, what's the primary cause of death, and then due to or as a complication of, and these are separate lines, and then the physicians fill that out when they fill out the death certificate as well.
And again, that's separate from then we get the real rare cases where someone is sick, they have not seen a doctor, they're not being under medical care at the time. And I bring up Kaylee Cook's situation, and that those factors all kind of played a role. That's why, by the way, that one gets questioned more.
Right.
That a decision was announced at one point, but it really was announced without having all the other things we would normally have in place. So that's why the extra step is taken. Okay, let's go ahead and get the autopsy and go through. Right. Even though, as you had said on this show a few weeks back, likely what was said at first about this being COVID-related death is going to be accurate. But let's just make sure. I don't want to put words in your mouth, but that's pretty much what you said on the show.
That's right. That's right. I mean, we do know that she had tested positive for COVID. That's number one. And then, but it also brings up the question as why even a 4-year-old would die from COVID. And so there are things that we just don't know about her because she was not in the care of a physician, and we're still waiting for the results of that. And quite frankly, I have no more information on that than what I've already told you.
Right. And I wanted to, and I didn't want to dwell on that. It was about time for us to kind of bring up an update on it, because a lot of folks are concerned about that.
Right.
That there's something else out there because they're worried about their kids, which gets into our next question is, the vaccine approval for those younger than 12.
Yeah.
Where are we on this? I know you and I talked about this Friday, but I want to give an update for folks that we had a lot of questions about this last week.
Yeah, so we expect the FDA to meet, advisory board to meet on October 26th. And from everything we've seen thus far, we expect an approval for 5 to 11-year-olds for the Pfizer vaccine. We expect then to go to the CDC's committee called the ACIP, the Advisory Committee on Immunization Practices. And that committee, I think, meets November 3rd. Our best guess is that we will probably receive the vaccine the week after. It's going to be a slightly different vaccine than what the adults are getting. It's a different dose. It's a smaller dose. Kids are smaller. Kids have really good immune reactions, even though they don't get as big a dose as adults do. And also by giving them a smaller dose based on weight means that their likelihood of having toxicity is going to be less. So everything you look about it, it's really tailored just for children to make it as safe and effective as possible. So we're already in discussions about how we're going to roll this out. We don't think having a drive-through is really the good way to do it because, sometimes, kids squirm around. Sometimes kids don't want to get vaccinated, and mom and dad's got to hold them down. And then we also want to make it a much more friendly environment and, give lollipops and candy and stickers and all the things that kids really like when they go through these sorts of things. So, we're talking about potentially having some kickoff events in around the county and in conjunction with UTMB, and then having it in the clinics, UTMB's clinic, our clinic, Coastal Health and Wellness Clinic, so that parents who don't want to go to the kickoff event have a place where they can go and get their child vaccinated.
But as I understand it too, how what's being worked on for those is to have more one-on-one versus mass.
That's right.
On this approach for
that's
those
right.
under 12, correct?
Yeah, that's right. It just, and we've talked to the pediatricians and we've talked to nurses and people who give vaccines, and everybody agrees that this is probably a better way of doing it, of spreading it out. So we're going to be asking parents, are you planning on getting your kid vaccinated? We're working on a short survey that we're going to ask the schools to send out. And so if you get one, please answer. And if the answer is no, please tell us no, because, that helps us out. Even if you don't want to get your child vaccinated, we know how much to plan for, and we don't want to order a bunch of vaccine if we're not going to use it, and plan things that nobody's going to show up for.
We were talking about kind of the magic pill approach. Merck, announced recently here about their COVID-19 pill. Thanks to the folks at Merck, by the way, who this morning allowed access to some briefing on that. They also sent us some video, which is very nice of them too, because it always is nice when we get to show off something a little bit more than just seeing Dr. Keiser and I's face show up on screen here. This is from Merck here, but they sent over a lot of their data. That's already publicly available, by the way, on this pill. One of the things is I take it they were a little sensitive to what I had commented on the show last week. This is going to be expensive. Before I even got into the question, they said we're already looking at ways of making this less expensive for folks, which I thought was kind of interesting. I don't want to take credit that they're watching you and I show. Maybe they are, but it was really nice that they were sensitive to that issue here. But what do we know about the Merck's? And I'll never get the name right of this thing. I tried to pronounce it on the phone 5 times with them today, and I couldn't do it.
I think we're going to have a song.
Antibodin or something like that. It was really hard for me to pronounce the term Molnu.
Yeah, that's why they have
Molnu capsule.
Prevenir, but it's so this is a drug that directly inhibits the COVID virus, and in my field in infectious diseases, we have a lot of drugs that inhibit viruses, HIV, hepatitis C, influenza. Have a lot of experience using them. And so this is something where people would take this medication for, I believe, 5 days, but you take a couple pills twice a day, and it actually reduces the rate of hospitalization and death by half. So that's really big. And because what it means is that instead of saying, oh, I've got COVID, oh, now what do I do? Oh, I need the antibody infusion and trying to get an infusion. We can have system where we have testing, in doctors' offices, and we're getting to the point now where that's becoming very widely available. It's very doable, and that they can actually have pills in their office, or the pharmacy right next door can have the pill. So it's like, here's your script. I was going to say I was going to write the script, but these days it's all done on computer. So boom,
Right.
boom,
Yeah.
boom, click, bum. It's all, the prescription's already in the pharmacy before you even leave the doctor's office, and then you go pick it up. So, I think that as this gets rolled out, a couple of questions is what will the demand be, and also can it get out? And I expect it's going to be pretty high demand. I think it's going to be very popular. As what will the demand be? And then the second thing is, can they get it out to people enough? I think the expense is a real issue, but having worked with pharmaceutical companies for a long time, what they do is that they price these pills to get maximum reimbursement from the insurance companies, and then they work on other ways for people to get it, so that if you're serving poor people, it costs less. If you don't have any money, you can go get a coupon, and so there's all sorts of ways. So I suspect there will be very few people, if any, that really do without because of funds. But we'll have to wait and see.
Do you hold out promise that we'll see more of this type of development?
Oh yeah.
And that goes into what I wanted to kind of get into as well, was how much of where we're going to get away from necessarily focus on the vaccines to treatments, to therapies, to other medicines that once you get sick, you take them. Just like we do for anything else out there. How this is a big step toward that direction, is it not?
No, it really is, and so, but this is just the first step in terms of oral medications, and so what it means is that you don't have to be in a hospital setting or an ER setting to get treated for COVID. It means you can get treated at home, and secondly, if this follows the pathway of what we've seen with other viral diseases, the next step is there's two next steps. And one is that take it to prevention, not so much that you take it all the time, but if you get exposed to COVID, and as more and more people get immune, we're going to see less cases of COVID, and so people will know, oh, I've been exposed because I know somebody that's got it, or I heard about this, and someone from the health department say, hey, you need to go take something to keep you from getting COVID. So prevention. But the other thing we'll also see is, remember, this is just the first pill, and so we're going to see more and more pills like this that both are easier to take, have few side effects, and also potentially can treat other viruses other than just COVID. So again, I think this is all part of this revolution in healthcare and health technology that we're seeing happening in front of our eyes because of this pandemic.
That's not the only one kind of on that same subject line I want to talk about. And I know you don't know details of the specific vaccine that I'm talking about, but this is an article in the Texas Tribune. I'm going to put up a link to it now so people can look at it. I came across it this morning, and then I do have a phone call into Dr. Peter Hotez from Baylor College of Medicine, who has, is like you is on air with us a lot talking about things. He's more of the Houston side of things, but he and a partner have developed a vaccine that, based on it's made right here in Texas. It's called Corbevax or Corbevax. And right now, the only taker on it to manufacture it is in India, where, of course, they had what we know is the Delta variant. That was the Indian variant.
That's right.
So folks don't understand that it was just ravaging their country. This is an interesting thing that they had developed this vaccine for $7 million, which that's a very low number.
Oh, that's
we get this world, is it not?
Right. Yeah.
And the whole goal of developing this actually was so it can get into poor communities, poorer countries, and the like. But it is interesting because it's another option out there. I do encourage folks to go and read this article. It's in the Texas Tribune. I put the link up. It's called "It's Cheap, Easy to Make, and in Demand Overseas. So why can't this Texas-born COVID-19 vaccine break into the U.S. market?" And that's what I was going to get into is that we hear a lot of the big announcements from Pfizer, one of the largest drug manufacturers on the globe.
Yeah.
And then we hear it from Moderna, and we hear it from some big heavy hitters. But then you have, and you used a term when you and I were talking about this. It's kind of orphan
drugs. Yeah.
Orphan drugs.
Right.
Which this is another topic I think that has to be talked about but can you explain first what orphan drugs are?
Yeah.
Because it would relate to this. And what do you hear that of, hey, who else is still developing vaccines, treatments, and there's a lot going on that we actually are not, it's not making the news, I should say.
Right.
That, and I'm not saying this in such a way, it's not making the news for a bad reason. It's just, it's happening, and, and something may come along later that may be an option for folks, but using this as kind of the kickoff point to that.
Yeah. So the idea behind an orphan drug is a drug that there's not enough demand for it to be developed commercially, i.e., nobody's going to make any money on it. And so finally, what the FDA has decided to do is for orphan drugs to allow for these drugs to be developed, but not have necessarily the same stringent criteria, realizing that there would be small numbers of people who would want it and who would need it. And we see this with a lot of, rare diseases and things, and parents are in tears saying, I can't get this drug for my child, or they got this drug because they were in a study, but now the study's over and the FDA won't approve it, and so they need it. So that's the idea behind it. Is that it's not a real commercial drug, and so you can see a vaccine like this, which didn't cost a whole lot to develop. It was developed particularly with the developing world in mind. It doesn't require refrigeration. It's basically old style technology. It's like the tetanus vaccine. You take a little piece of and make a protein out of it, and then you inject it into people, and they were able to get some really good responses. And although it's old technology, I assure you they used 21st technology in designing which piece of protein and which the things that went into it. It's just the delivery system is an old-fashioned thing, and it seems to work and work pretty well. So it's going to be tough for them to get FDA approval for something like that, because in the FDA, the United States, you have to have studies that are done in the U.S. And right now, we can't find people we can't give away vaccine to people, right?
Right.
We've got a whole group of people who don't want it. All the people that really, really wanted it have gotten it, and now we're talking to those people that are, gee, I'm not sure, I don't know, and trying to get them to become part of the whole thing about getting vaccinated. So it wouldn't surprise me that it's going to take them a long time to get this whole thing developed and get it approved. That being said, there are a lot of vaccines. Last time I looked I think there were 26 candidate vaccines being developed in the United States. That doesn't include things like the Russian vaccines, the Chinese vaccines. Chinese vaccines have been a disappointment. They haven't worked all that well. The Russian vaccine, interesting, they call this one called Sputnik, is not approved by the WHO. It's not on their list. The Russians don't release the data on it. But people that I know that study vaccines say it's a pretty good vaccine. So it's just a crazy world we live in, with all of the different overlapping jurisdictions and requirements to get things approved. And then, of course, there's commercial viability, there's national pride, there's need to get it to places where nobody can use it. The vaccines that we've developed in the United States, the Pfizer and Moderna vaccines, are some of the best vaccines that have ever been developed. But unfortunately, you can't put them on the back of a truck and take them out into the middle of nowhere in Africa or Guatemala,
right?
Because they'll fall and they won't be any good.
Anyway, I found, as I said, this specific one, Corbevax, I think I'm pronouncing it correctly. You can look it up. The Texas Tribune. The article came out yesterday. I didn't get a chance to read it today. I put a link on the site to take a look at it. I'm having interviewed him a couple times. I'm going to ask that Peter Hotez come on with you and I one week and maybe talk about this. I think it'll be good to talk about as we kind of get into this phase of looking at, hey, what's next? What are we going to be talking about along the way? I would like to get to that as well. Let's go ahead now and get into our viewers' comments. I know you have to be right away today. Last week you did too, but I think we got a little.
No, I'm flexible today.
Got it. Okay. So we're going to start off. Jasmine Rab had this question: how long after testing positive for COVID can I get vaccinated? We get this question a lot.
Yep. As soon as your symptoms go away. That's actually as soon as your fever goes away, pretty much. So when we say symptoms, sometimes people feel weak and fatigued for a long period of time, and it's still okay to get vaccinated. But as long as your fever is gone, it's okay to get vaccinated.
Somewhere along the same lines, but she has a little more concern about taste and smells. Jeannie Latham, how long before I get my taste and smell back? Is the 10 days of quarantine enough? Should I test negative before public appearances?
Yeah.
I know that's a concern for a lot of folks who like to get out and about. Jeannie's one of those. She's out and about all the time.
Yeah.
But first, let's get into the first part of my taste and smell. There is no kind of exact on that, right? There are folks that it's a long hauler and some is short term.
Yeah, it's a funny thing. We're having some people that, they didn't even notice that they were sick. They simply noticed that they weren't smelling anything. Okay. And then they got tested. And then we've had other people that have lost their taste and their smell for a long period of time. One individual I know was about 10 months. And then they got another infection, which wasn't COVID. And then when that resolved, suddenly their taste and smell came back, right after that infection. So it was, something reset. So, we know the virus gets into the brain, and we know that, your smell, a lot of your taste really has to do with your smell. And the nerves that allow you to smell come like right out here and goes directly into the brain. And once that's affected, it can last for a long period of time. So we don't know what it is, why some people get better very quickly or why some people take a longer time to get better. I know people that have had problems with prolonged difficulty with taste and smell. They're miserable, because they can't enjoy food and they feel like, there's something wrong with them, that it just doesn't go away. And it's a constant reminder that there's something going on. That being said, as long as your fever goes away and 10 days of, 10 days with at least 1 day without fever, without taking Motrin or Tylenol, then you're not considered infectious anymore. So, once you get past that quarantine period of time, you're okay, even if you're not necessarily feeling as best as you can.
Gotcha. Jeannie had a question right after that too. Want to get at how long after a positive test do we wait for a flu vaccine? I know this answer. You don't have to wait.
Yeah, don't wait. Yeah, go get your flu vaccine.
You get your flu vaccine.
We hate you to get COVID and then get flu and get really sick from flu because you had COVID.
And you've actually said get them at the same time if you can.
Sure, absolutely.
Right, your COVID vaccine and but need to wait on your COVID vaccine if you've tested positive for COVID until make sure all your symptoms are gone.
And that's the only thing that we ask people to do. Wait until your symptoms are gone. Wait till the fever's gone, then go ahead and get your vaccine.
Gotcha. Regina Haley has this question. I think this will come up now because they're looking. At least folks are paying attention to what the boosters differences are. So would it be better to get the 100 mcg or the 50 mcg Moderna booster? Without even looking anything about Regina, I think Regina has a nursing background here or something in that regards to efficiency and duration of coverage. We'll be able to choose doses.
No, but you'll be able to choose what you tell people. Not that anybody would manipulate the system. But basically, the 100 microgram dose is for people that are immune suppressed, okay? And the 50 microgram dose is for people that are getting a booster who don't fall into those categories. So if you're not sure, talk to your doctor, find out what the best dose is for you. That's my best advice at this point.
See, I'd even know, to tell you the truth, that existed that way until after I got my booster.
Oh,
it would not been good if I'd had a choice. I would have said, give me the 100. It's like the difference between leaded and unleaded gasoline, I think. For me.
In all honesty, I don't know what I got. It's just like, okay.
Neither do I. I don't either. But I just, I just when Regina's question came up, I had to go, I'm getting this one in. It's a good one because I'd heard about it and I didn't pay much attention to it. So Regina, thanks for that. That's a good one there. You can't request a specific thing unless you tell them a certain thing. So that'll go along the lines there, so you can have that. Let me. I skipped over that. And you already answered this, but Regina also asked this question: will the health district offer another drive-through vaccination drive at the Galveston County Health District? I think she's talking about on the boosters and the like. It's not a drive-through anymore. It's coming inside, correct?
Right. Because we haven't had enough as much demand. It's really interesting. When we first started doing the boosters, we had lots and lots, and lots of people coming through. So much so that the best way to do it was with the drive-through, and then demand decreased. And after the hurricane, we shut everything down. So we would be prepared for the hurricane, and then the demand didn't quite come back up, and we were able to do it inside. And even last week, we probably, we were doing up to 1,000 people a day. I think we may have done 500 people total last week.
For the whole week.
For the whole week, yeah. So what's available goes up and down depending on what the demand is and what the needs are.
And just that we have the information up there for you if you're interested in the booster, as well as the regular vaccines schedule for you. You can go to the health district's website. We have a specific link you can go to, but if you go to the Galveston County Health District, it'll there. The clinic is open. This is walk-in. I'm not walk-in. You have to get an appointment, but it's walking in.
Right.
8:30 to 3:30 Monday through Friday, but on Wednesdays it's open till 6. So for those who want to get out later to do so, that's available for you there to take advantage of that. Let's see. And this is about the mix and match stuff. Is J&J people get Moderna? Would they get the 50 or 100? We're getting that again. But J&J, if you mix and match, the recommendation really is you go for the whole thing.
We'll see October 26th what that.
Right.
I feel like we're announcing a movie coming. Playing soon in the theater near you. We'll see what that recommendation is. I wouldn't be surprised if they say the 50 microgram dose, in large part because that 100 microgram dose is for people who are not mounting a good immune response. So, and it's not because they didn't get as good a vaccine, it's because they didn't mount a good response to begin with.
The question we're getting, and this is kind of mixed messaging, so that's why we're trying to, can anyone get a booster, or do you have to be within an over 65 age group or have underlying conditions?
Right. So there's actually quite a long list. And so in general, it's two categories. It's over 65 or underlying conditions, or someone who's at high risk for getting COVID. And those we're including frontline healthcare workers, teachers, certainly police. Believe it or not, the biggest killer of police in the United States today is not gunshots. It's not automobile accidents. It's COVID.
It's COVID.
And so people that are, frontline first responders, those types of things. We actually have a very long list of people. And if you're not sure, ask. And we're always going to work from the position of giving people the benefit of the doubt, not keeping people out. All right. But there may be some people where it just turns out we say, okay, well, it's really not time yet, so just wait a little bit.
Right. But 20-year-old shows up in good shape, had both shots beforehand, no underlying conditions. You're probably going to say, okay, wait a little bit.
It's probably going to be okay, right?
And it's also one of those things too, even though this is not a supply issue. This is just what the recommendation is right now, correct?
It's what recommendations are, and it's an issue of trying to make sure that it's really safety issues more than anything else. So what all of these panels are doing, they're weighing the risks and the benefits. And so clearly in older people and people with high risks of having a bad outcome with COVID or high risk of getting COVID, the risk of having a third shot of the vaccine outweighs the benefit. For a healthy 20-year-old, maybe not. I don't know.
Another question came up here now. Kathy Ozenberger asked this question, and she asked it about how contagious. What about how contagious are you after the booster? This also comes up with how contagious are you just with the vaccine? Right. One of the things is that we need to probably explain this to folks again, that just because you have the vaccine doesn't mean you can't spread COVID.
Right.
So can you explain that to folks? 'Cause I think this gets confusing to folks.
So the first thing it's important for everyone to understand is that this is not a live virus vaccine. So it's not like I get the vaccine, I have the virus spreading in my body, and then I can spread it out to other people. That doesn't happen. And the way the vaccine works is that it gets inside of your T cells, which are what make the antibodies. It makes this protein for COVID, and then the body reacts to it and it makes antibodies. There's no COVID inside anyone's body. There has been a lot of misconception, misinformation, in some cases even lies about, oh, well, you get the vaccine and then the spike protein gets in your nose and then it can infect someone else. And it just doesn't happen. The spike protein doesn't cause infection. You need the whole virus. So that doesn't happen. All right. So that's number one. Now, the next thing is that if I get the vaccine, can I get COVID? Yes, you can. The chances of you getting it are very, very low. But if you get it, you can then, particularly with the Delta variant that we have now, you can then spread it to other people. So that's why, we're asking people to, particularly people that are high risk, that even if you've been vaccinated, to continue to wear masks when you're inside in public places.
Here's another topic we covered somewhat Friday. The good one to always bring up. This is Brian Shaw saying, don't get the shot if you've already had COVID. Your own antibodies are way better than any shot they have. And I'm stressing the way what he says here.
Yeah.
I'm going to go ahead and let you have this one. I know we already talked about that. So.
Yeah, well, I mean, based on the data that we've seen, including here in Galveston County, it's not way better. It's probably about half as good as a vaccine. Okay. So what that means is that if you had COVID and you survive, all right, or you don't get really sick and you don't get long haul, you don't have all the complications of COVID. Most people don't. But if you get COVID and you recover from COVID, your chance of getting COVID is much less than someone who's never had COVID. Okay, that's true. But it's still about double of someone who's gotten the vaccine. So one of the things that's being discussed is what to do about people who have already had it. How do we boost that immunity so that it lasts and you get the same protection? What I encourage people to do who are curious, and Brian, I would put this challenge out to you. Why don't you come and just get one shot, see how you do? Okay, it's going to boost your immunity. It's going to protect you. But if you're worried about, the side effects of the vaccine, it's only one shot, so you're probably not going to have the same side effects. And then you can decide whether you want to get the second shot.
Yeah, and that's the same advice you gave last week, which I thought at least is kind of reasonable along those lines. But the data has shown that it's not as effective as the vaccine.
It's not as effective. It's good. It helps prevent it. People seem to do okay. We don't have very many reinfections. But we have seen reinfections, and we see those reinfections that get hospitalized. So, it can happen.
Is there data being collected on reinfections versus reinfections of those who had COVID but not vaccinated versus reinfections of those COVID vaccinated then reinfected?
Yeah, we've got all that.
It's somewhere.
Yeah, we have it. One of the big problems is that the CDC did not initially collect this data, so they're playing catch up with this.
Right.
So, the data that we have is, we've only got 50,000 people that have been infected, and believe it or not, that's a pretty small data set for this particular illness. So what we can tell you is that out of 50,000 people, hundreds of them have gotten reinfected, and a couple of them have died. And some of them have ended up in the hospital. Some of them had a vaccine and still ended up in the hospital with COVID after getting COVID and getting vaccinated and having it again. And you think about it, those are people probably like Colin Powell, who just had a very poor immune system. And that's why they're not responding, and that's why they're getting reinfected again. And so, there are many, many things that go into how you're going to respond to this virus and how you're going to be able to fight it off. And just looking at one factor really isn't enough. It's more complicated than that. So, we would encourage people who would recommend to people, if you've had COVID, go ahead and get vaccinated. And if you're unsure, just at least get one dose, and because that will certainly help boost you up a little bit.
Yeah, Brian, thanks for the comment though, because this comes up a lot. We like how you presented it. It's a lot better than most of the folks who present that subject matter. But it's good. It's a good discussion to have on that. When no one has said that having antibodies from an infection is not a good thing. Well, you don't want to have it in the first place, but it's in there. In there. This coming up because you've seen this for a lot, and Tracy Riley, who's a nurse, I know Tracy is a big follower of ours. She says she's been fully vaccinated, has a booster. She's saying, I've done this to protect me, my husband, and the public. Please get the vaccine. Here comes the part that I want you to comment on. Healthcare workers are stressed and overworked. Please get the vaccine. Now, we should talk about the capacity at UTMB Health and the other hospitals in our area has been pushed at times, but not pushed over the limit.
That's right.
That'd be a fair assessment. But give us your assessment when you've been in the hospitals or you talk to healthcare workers.
People have no idea how close we've come. I mean, it's just, that's true. I really have to give a lot of credit to Dr. Sharma and Dr. Harlan on how they've managed the numbers of cases of COVID in the hospital, how they've worked hard to get people to come and work, the angel nurses and other people. I got to give a lot of credit to my colleagues who, when during September, a call went out and basically said, look, a lot of the people that are doing this regularly, they're worn out. They need a break. We need some volunteers. And a lot of people stepped up and volunteered. And it takes a huge toll. We're exhausted. And even the people who work at the health department, not only exhausted from processing these things, if you look at death certificates day after day after day after day, another case of COVID, this is what happened, It's exhausting. It's emotionally and mentally exhausting. And we've been doing this for 19 months and we're worn out. And it's, I think for the most part, everybody's been a good soldier and done their duty and stood up when they've needed to. And so, you have no idea what, particularly the frontline nurses and doctors, what they've been through. It's been hard.
And we have a story coming out pretty soon. We're waiting for a couple more elements on this. One of the kind of the areas we kind of focused on was we went into the ward, I always call it the birthing ward, the delivery section of the hospital that is specializing in handling COVID cases. And one of the things one of the nurses that I spoke with, when I asked her, she's been there from day one. I said, I know nurses get tired all the time. You look a little worn out. She says, I'm more worn out now than I was last summer.
Yeah.
And she's working in an area, and this is something else one of the other nurses told me. She says, working in an area that is supposed to be a joyous occasion. Mom gives birth, the whole family is there, they're holding the baby, everyone's showing off the baby. That's not happening.
No, it's not.
Mom doesn't even have contact with the baby for a while.
Right.
The IVs are running through holes in the wall from the outside.
Yeah.
So that there's less contact.
Right.
There. That there are huge changes that are taking place within just the medical field. And we're hoping to show some more of that. This is not a scare tactic, folks. And nor is it me saying get the vaccine. While yes, I'd recommend it, Dr. Keiser recommended it. I'm saying take care of yourself with the best means possible, so that other people don't get sick. Because there is and this is the whole focus. I think needs to be stressed again on this show, as we do every single time. We have made a point of not focusing on the deaths. Yes, 553 people in this county or county residents have died. That's a 1% fatality rate from COVID-19. I understand that is low compared to anything that's out there. But we have said from day one, it is about hospitalizations and the stress on our medical facilities that has been the main reason we have been doing this show, to give people the information they need to help that out. That has not eased up, and that is not as low a percentage as people would say. It's still at one point, it was hovering around 10% going into the hospital.
That's right.
Is it maintained that or gone up a little bit? It
Yeah,
did go up a little bit.
it's still about a 10% chance of death if you go into the hospital. If you end up in the ICU, it's about 50-50.
Yeah.
And at one point in August, one of my colleagues she was just worn out, and she was going, the ICU is full, and the only way people are leaving is by dying. And that's a pretty glum, grim situation, and that's where we were. That's the reality of it. But we held on, we made it through, and everybody kind of thinks this is over, but it's not over yet. And we may have to go through it again a few more times before we really get through this.
And that's the main reason we're doing this, to give information for you to use to help that out, because there's this domino effect that's taking place, that when when healthcare is being devoted to things that's one easily be able to fix, to take care of on your own, not get sick about, that means people are not getting cardiac care unless it's an emergency situation. They're not getting prenatal care unless it's an emergency situation, because either they or the clinic's overrun, or they themselves have decided not to go in. We're seeing cases by cases by cases. You have said this on the show. And Dr. Sharma recently had talked to me about this. What the concern is, 5 years down the road, how many people weren't getting treated for other things right now,
right,
that are dying, or worse, that dying is worse, but dying are in a more chronic, or find themselves in a chronic case of something that should have been acute, along the way, because things aren't getting taken care of now.
Yep.
How close are we to seeing a huge influx of patients 2 years, 3 years, 4 years down the line that shouldn't be there because of other ailments? I'm not going to even talk about COVID.
Right.
Other ailments because of what I'm calling the COVID effect.
Yeah, well, time will tell, right? But we know that people are having waits to get to see cardiologists, to getting to see other specialists, because things have gotten all backed up. We also know that just general access to outpatient clinics, because of all the things we have to go through with COVID, has become longer and more difficult. And so we're seeing these trickle-down effects throughout the whole system. And I think that we're really not going to know for another 4 or 5 years just how much of a toll this took on other areas. And we won't know it until we have a chance to see what happens and do those types of analysis that really let us know what the effect is. But it wouldn't surprise me if we continue to see the downstream ripples of this for a very, very long time.
You lost me there.
Okay.
I had a power surge just as you were getting into that. I hope you kept talking for a while.
I did. I was talking the whole time, and then I
good.
just
Okay.
Good. I go.
Forgive me, folks. I went on script. We had a power surge here that took our virtual studio offline, and so forgive me. Hopefully, I went out too far along there. That was our wrap up anyway for that. So thanks for filling in on that. See, you're so experienced at doing this now. You can host the show by yourself. You don't need me any longer. Any final thoughts before we wrap up here today?
No, I think we're in a good spot compared to where we were 2 months ago, which is really, really good news. I think everybody's happy and breathing a sigh of relief, but it's not over yet. Our numbers are really not down to the lowest that they've been, and so we still have a lot of cases out there. We got a lot of people in the hospital, a lot of people in the ICU, and it's important that people do what they need to do, and that includes things like get vaccinated, continue to wear a mask, be cognizant of where you are when you're going out and going other places, and just be careful. We want people to be safe. We want people to be healthy.
And looking at the number down, number of total positive cases, 53,000. A good sign here, though. Active cases as we speak right now, 1,900.
Yeah, less than
a lot higher at one point.
Oh yeah, it's less than 2,000 for the first time since I don't know, maybe June.
Yeah. So that's good there to see that. That's what I was trying to bring up when we had the power surge. there that came on. And I was going to bring up this is current hospitalizations that we're going to be bringing up for folks to look at now. Now, these are Galveston County residents in the hospital. This is not total people with COVID in our hospitals in our area. It's important to know that. But as you can see, it's about 76 people in the hospital right now. That's dropped down because it was over the hundreds for a good while there.
Oh, at one point it was reaching 200. That was pretty scary because that was kind of our threshold for a meltdown.
Yeah, gotcha. Dr. Philip Keiser, the local health authority for Galveston County, as always, on with us. We appreciate you being on with us, Dr. Keiser. And again, if you have questions, we'll be back on next week. This quick visit, even though we covered it up, not covered it up. That's going to come. That's going to come back and bite me.
What are you covering up?
I will admit right now that someone's going to use that against me. So, see, it's told the truth. Finally, it's no. We've covered this issue. We covered a lot of these issues last Friday, but a lot of folks that are not used to seeing us late in the week, and it was good to have them on. Reminder to you folks, our continuing series for Healthcare Unmasked, and that's the other thing I was trying to pull up that I wasn't able to. Continues tomorrow as we focus on breast cancer, and we'll be on at noon tomorrow here with UTMB health officials. So make sure you join us for Healthcare Unmasked that tomorrow. And we look forward to having you there. Dr. Keiser, thanks for coming on. We appreciate you, sir. This has been another edition of What You Need to Know, COVID-19. We'll look forward to, if you have any more questions, you can send them to us or post them in the comment section. As you see, we always get to those as well. Have yourselves a good one. We'll talk to you later.
Okay.